So again, what I want to talk about today is our current thoughts about treatment and management, as well as our research efforts for what's really an uncommon type of melanoma. This is a very educated audience, and I'm sure there are people here who've never even heard of eye melanoma before. But I'm going to talk a little bit about that. And when I talk to people dealing with cancer, I like to start off with this slide. You know, all of us here are affected by cancer. I think all of us have asked at one point or another, who do we consider a cancer survivor? And this is a definition that was put out by the National Coalition for Cancer Survivorship. And they say that an individual is considered a cancer survivor from the time of diagnosis. So from the time of diagnosis through the balance of his or her life. They go on to state that family members, friends, and caregivers are also impacted by the survivorship experience and are therefore also included in this definition. And I think this is an important definition for two reasons. One, it emphasizes the point that we have to start thinking about the impacts of cancer at diagnosis, not after we've completed therapy, but what are the physical, medical, psychological, social, even financial effects of the cancer diagnosis. We have to start thinking about that early on. You know, and that'll help, I think, optimize the way we can help care for patients with cancer. And the second point is that they also state that family members, friends, and caregivers also have to be considered in this diagnosis because everyone is affected by that diagnosis. When we think about what people go through as they're diagnosed and treated for cancer, we can think of the stages as these four here: the stage of initial diagnosis and workup, the stage of active therapy, the stage of maybe consolidative therapy or close observation, and then finally the stage of long-term survivorship. And each of these stages certainly warrants a separate lecture, but what I want to focus on today is kind of the stage of active therapy for uveal melanoma. What I want to focus on today is, one, what is uveal melanoma? Two, what are the FDA-approved treatment options that are at least available for this disease? Three, I want to spend a lot of time actually talking about the clinical trials that are being conducted in the US and around the world specifically for this disease. And then finally, I want to make sure that everyone here knows how to find an appropriate clinical trial. Because the work that Dr. Hody presented, the work that Dr. Kim presented, that couldn't have been done without people like you helping us participate in the clinical trials. So ocular melanoma, it's actually a family of diseases that occur in the region of the eye. And the most common site in the eye is the uveal tract. The uveal tract is made up of three areas in the eye. One is something called the choroid plexus, which is really just the vascular layer of the eye between the outer sclera, which is the white portion of the eye, and the inner retina. It's also made up of, it also includes the ciliary body, which is this ring of tissue that surrounds the lens of the eye. It helps change the shape of the lens, and it also secretes the aqueous humor that fills the front part of the eye. And it also includes the iris, which is the pigmented part of the eye that surrounds the pupil. Ocular melanomas can also arise from what's called the conjunctiva, and this is kind of the thin membrane that surrounds the outside of the eye. It also lines the inside of the eyelid. That's less common, and even less common, melanomas can arise from the orbit or from the eyelid. And again, what we're going to be talking about today is uveal melanoma, or melanoma arising from the uveal tract. So of the 69,000 cases of melanoma diagnosed each year in the United States, about 3,000 of these are actually ocular melanoma. Despite the rarity, this is actually the most common primary eye cancer we see in adults. Represents about 5% of all melanomas. It is a different disease than skin melanoma. Although it arises from melanocytes, which are the pigment cells in the body, just like skin melanoma, you know, the reasons it becomes cancer, the way it behaves, the way it responds to therapies are a little bit different from skin melanoma. We're going to go through some of that. We can use local therapies like radiation, surgery to take out the eye, and that can be curative in some cases of eye melanoma, but unfortunately, despite aggressive therapies like that, it can recur. And once eye melanoma recurs, this is a difficult disease to treat. That's true for skin melanoma. It might even be more true for eye melanoma. And for that reason, people have put in a lot of effort to try to find treatments that maybe that we can do in addition to surgery, in addition to radiation, to help reduce the likelihood of it coming back. In terms of FDA-approved agents that we have for the adjuvant therapy for melanoma, I think you're all aware of, there's really just the one drug, which is interferon. And now, last year, there was a long-acting form of it called pegylated interferon that was approved also. This is really the one drug that's approved for the adjuvant therapy of melanoma after resection of disease if they're at high risk of recurrence. But the studies that got this drug approved were conducted in patients with skin melanoma. I'm just going to quickly go through that data so you're aware of it. The first study that got that drug approved was something called ECOG 1684. And on this study, patients with, again, high-risk skin melanoma were randomized to either close observation or a year of this interferon therapy. And the interferon, it was an IV treatment. You got Monday through Friday, 5 days a week, and then you gave yourself shots in the belly 3 times a week for the rest of the year. And what they showed is that actually with a median follow-up of 7 years, they found a 9% survival benefit at the 5-year time point. And patients seem to do better in terms of living longer if they got the interferon. And I'm happy that Dr. Hody and Dr. Kim went through how to read these curves, so I don't have to go through this too much. But basically, this is a survival curve here. On the x-axis is the time in years. The y-axis is the probability of the patient still being alive. So at time 0, everyone's alive. And ideally, the line just goes straight like that. And here you can see that the interferon line, which is this dotted one, is kind of closer to that ideal. And so this is what got the drug approved. The follow-up study to that was something called ECOG 1690, where a similar patient population was randomized to either that high-dose interferon arm. They also tried a low-dose interferon arm where patients got shots in the belly 3 times a week for 2 years, and there was a third arm for observation. And like with that first study, it seemed that there was a benefit in terms of delaying the time of the cancer coming back if you got the interferon, and that's the dotted line here as well as this dark line, compared to if you were just observed. This was only what we call statistically significant if you got the high-dose regimen. But unlike 1684, in terms of survival, there actually didn't seem to be a benefit or any difference. All these lines kind of just all overlap. And so this kind of illustrates for you some of the challenges I think we as physicians and patients face when deciding, what does this data mean? It's great if all the data says the same thing. If it all says yes, it helps, well, we'll use it then, but that's not the case for interferon. And I think for patients here who have cutaneous melanoma, who've had this discussion, you probably know that it's a long discussion between the doctor regarding the potential benefits as well as the potential side effects of therapy to decide whether or not to do that. So that's a big prelude to ocular melanoma. So the question is, do we have any data for interferon in uveal melanoma? And we don't have a whole lot. There's one study that really looked at this from the Mass Eye and Ear Hospital, where what they did was they looked at 121 patients with high-risk ocular melanoma. And they defined that as patients over the age of 65, patients with a big tumor, patients whose tumor involved the ciliary body, which is a ring that surrounds the lens, or a tumor that had extended outside of the sclera, outside of the eye. And these patients were either treated with proton beam irradiation or enucleation, and then they treated them for 2 years with that low-dose interferon regimen, the shots in the belly 3 times a week for 2 years. It wasn't a randomized trial. They looked at those patients who they put on the study and then kind of looked at historical controls and tried to see, is there any sort of difference? What this just shows you is here that they matched the patients they treated with the historical controls quite well for age, tumor size, sex, and the presence or absence of extrascleral extension. There were actually more patients with ciliary body involvement in the interferon arm, and that kind of connotes a worse prognosis. Those patients tend to have more aggressive disease. But this is what the curves showed. This curve's a little bit different than the last one. The x-axis is here, and that's time. And then the y-axis is actually the proportion of patients who've passed away. So ideally, the line is flat here on the bottom. But you can see here that it looks like if you got the interferon, if anything, you maybe did a little bit worse, but this wasn't statistically significant. But this is the only data we have for interferon in uveal melanoma in any sort of rigorous format. there's some issues with the study. One, it wasn't randomized. You ideally want a randomized study to really see does it make a difference or not. And two, this study only tested this low-dose interferon regimen. But again, this is the data that we have. So we're still really looking to try to find better and new treatments in the adjuvant setting. It poses a number of challenges for us, though, and I've listed some of those here. One of the challenges is what treatment should we test in this setting? Typically, we'll test drugs that have been proven to be effective in the advanced setting and then move it forward earlier. But as I'll show you in a little bit, we're having some trouble finding those effective drugs in the advanced setting. 2, which patients should be enrolled in the study? Should it be all comers or patients with just very aggressive disease? 3, what defines a positive study? Ideally, we want the drug to prevent the cancer from coming back. But is that how we should design the studies? That has impacts as far as how big the study is going to be, how long it'll take us to find the question or answer the question. And then 4, how many patients are required to prove that a treatment is effective? That's particularly important in a disease that's uncommon like this one. So in terms of ongoing current clinical trials in the adjuvant setting, worldwide there are just 3 right now. There's a vaccine study being conducted in the Netherlands. The Cleveland Clinic is studying the combination of chemotherapy with DTIC with interferon in this setting. And then this group in San Diego is studying the combination of chemotherapy, sunitinib, which is one of those new targeted agents, and then anti-estrogen therapy. I think the paucity of the number of trials that are being conducted is reflective of the challenges that we're facing in trying to actually develop these good trials. What I've put on here is something called the clinicaltrials.gov number. I'm sure most of you know about this website, clinicaltrials.gov, but if not, I just wanted to kind of talk a little bit about this because I think this is really important for patients everywhere. But clinicaltrials.gov is the service of the U.S. National Institutes of Health. It offers up-to-date information on federally and privately supported clinical trials for really all diseases and conditions. And at least as of November, it listed nearly 120,000 trials conducted in the U.S. as well as around the country. So I think for patients who are interested in clinical trials, this is an invaluable resource. Okay, so here we are with a timeline for FDA-approved drugs. This is the interferon, which is approved for the adjuvant treatment of cutaneous melanoma. And as Dr. Kim went through, before last year, we had 2 other drugs that were FDA approved for use in the advanced setting. Again, primarily based on studies looking at cutaneous melanoma. That was DTIC, the chemotherapy, and interleukin-2, which is the immunotherapy. And then also, as you've just heard, last year was a big year for us. We had 2 new drugs approved, both of which, for the first time ever, showed that they meaningfully impact survival. And no other drug before that's been studied has shown that, and that's the Ipilimumab and vemurafenib. The studies that got those drugs approved were done in patients with skin melanoma. Okay, so again, the next question for us is, what does that mean for eye melanoma? Now, the next set of slides it's a little bit of, I don't want this to be too repetitive because Dr. Kim went through this, but just to kind of summarize, the rationale for BRAF targeting is because we know that about 40 to 60% of melanomas harbor that BRAF mutation, which activates this growth pathway constitutively. And so if we can shut that off with a drug like vemurafenib, we shut down that signaling, we decrease the growth of the cell and lead to tumor death. As he showed you, the pivotal clinical trial randomized patients with BRAF mutant melanoma, again, this is skin melanoma, to either vemurafenib or dacarbazine. And he showed you these waterfall plots. And again, on the waterfall plots, each bar here is a patient. If the bar goes below the x-axis, that's good. That means the tumor shrunk. If it goes up, it means the tumor grew. And for DTIC, the likelihood of major shrinkage was 5 or 6%. Whereas if you look at the waterfall plot for vemurafenib, you can see that most of the patients fall below the x-axis. Overall response rate's 48%, so that's a dramatic difference, also with improvement in progression-free survival and overall survival. So can we use this in eye melanoma? Well, the key here is that that drug only works if the tumor has a BRAF mutation. And there have been a huge series of studies listed here that have actually looked at eye melanoma samples for the presence or absence of these mutations. And what they found here is of 276 samples, none of them had a BRAF mutation. They also looked at NRAS, and none of them had an NRAS mutation either. As Dr. Kim alluded to, the effects of treatment with vemurafenib, if the cell doesn't have a BRAF mutation, certainly you wouldn't expect an effect. And what we did here is we took a number of uveal melanoma cell lines and we characterized them for kind of these key mutations. So this one cell line had none of the key mutations in BRAF, something called GNAQ, which I'll talk about in just a little bit, or something called GNA11. Some of these actually had BRAF mutations, and a couple of them had a mutation in this GNAQ. As you can see, in the BRAF mutant cell lines, so we're treating them with something called PLX4720, which is the laboratory version of vemurafenib. And you can see that the viability of the cells decreases if we treat them with higher doses of the drug. So it works in the BRAF mutant cells. Here, you can see that it's flat. There's no effect on the wild-type tumors. But actually, if you treat the tumors with a GNAQ mutation, certainly there's no benefit. Maybe there's even some growth. And here we just show that treatment with that drug shuts down that pathway like Dr. Kim showed previously, but only if you have that BRAF mutation. It doesn't do anything in the wild type or the GNAQ mutant cell lines. So for this reason, treatment with vemurafenib in the vast majority of ocular melanomas isn't going to be a viable option. How about Ipilimumab? So this is a slide. I'm glad Dr. Hody went through this because this is a complicated slide and he explained this much better than I could, but basically Ipilimumab blocks the CTLA-4 antibody, allows for continued T-cell potentiation. And I'll just skip through this, but clearly on his study, there's an improvement in survival if you got the Ipilimumab versus if you didn't. So how about ocular melanoma? Well, again, the published literature is a little bit sparse, although I think a few of us are actually putting a larger series together. But this is what's out there right now, and this is a European experience. They recently published their experience of 13 patients, so it's a very small series. All these patients had uveal melanoma that was metastatic. And this is how they reported it. It's a little bit confusing, but I'll try to walk you through it. Here, patients got injections of the Ipilimumab 1 day every 3 weeks for the induction, and then they got it at 12-week intervals subsequently. So they got shots at week 1, 4, 7, 10, week 24, and then week 36. So at the very beginning, 13 patients started, they got their first shot. By week 12, 4 patients had actually been taken off the study already because the tumor had grown too fast, and they couldn't wait for the late response that Dr. Hody showed you previously. At week 12, at that point, 2 patients had actually shown control of the tumor. There was no growth, but 7 patients had evidence of tumor getting bigger. But because of the possibility of late responses, they were kept on treatment. By week 24, unfortunately, another 4 patients were taken off for disease progression. At this point, 3 patients actually had disease stability. So 2 patients who initially had disease stability at week 12 were still doing well. 1 other patient actually, who had progression, actually developed some late stabilization. 2 other patients had disease progression. And by week 36, 2 more patients were taken off study. 1 patient at that point still had a durable, stable disease, but 2 other patients had progression. This patient who had disease stabilization actually had disease control for over 3 years. So it's a little bit hard to interpret this series. It's very, very small. I think what it does tell us, is that immunotherapy with Ipilimumab can work. It has helped some of these patients. One of the challenges for us will be how to identify those patients prospectively a little bit better. But I think this shows that immunotherapy can work. It's warranted. Further evaluation is warranted in this disease. So that's really it in terms of kind of what we have for FDA-approved drugs. The vemurafenib I don't think is really applicable in this disease. Ipilimumab I think is a reasonable treatment options. Now there have been a lot of clinical trials conducted in this disease in the metastatic setting, trying to find new and effective therapies, and there are a bunch more ongoing. Over the past decade, though, these are the drugs that have really been studied. And this is just a list of different clinical trials looking at chemotherapy, different targeted agents, combinations of chemotherapy, combinations of chemotherapy with interferon. And these trials over the past decade have, in general, been disappointing. The likelihood of major shrinkage on these studies was pretty low, and we didn't seem to help very many people with these studies. In fact, if you look at the 157 patients treated across all these studies performed over the past decade, we actually only saw two responders across all those studies. But I think there's hope. That's a depressing slide, so I'm sorry. But there is hope. I think the way we're thinking about melanoma has changed. We don't think of this as one disease anymore. Rather, it's a family of different clinical and genetic diseases. And certainly we know that 45% of these melanomas will harbor these BRAF mutations. And it was that observation that led to the approval of vemurafenib. If we didn't find these patients, and if we didn't select these patients for treatment, then that drug may not have been approved. Now, what makes up the rest of the pie? Well, we know that another 20% of cases harbor NRAS mutations, and there's ongoing work trying to target that subgroup of patients. A small group of patients, particularly the mucosal melanoma patients, patients with acral melanomas, patients with chronic sun-damaged skin melanomas, will have KIT mutations. And work that Dr. Hody has done and that our group has done has shown the efficacy of KIT inhibition in that subgroup. There's still a big part of the pie that's so-called wild type. That means they're wild type for the things that we're looking for, so we have to figure out what's driving those tumors. Now, about 4% of these melanomas harbor mutations in something called GNAQ and GNA11, and it turns out the majority of those cases are ocular melanoma. So my hope is that just like the finding of the BRAF mutations in cutaneous melanoma really sparked the progress that we've made in this disease, my hope is that the GNAQ, GNA11 finding in ocular may do the same. So what is GNAQ and GNA11? It's a little bit complicated, but these are genes that encode for the alpha subunit of this thing called a G protein. And this is the G protein here. It's made up of 3 parts, this alpha subunit, beta, and this gamma subunit. And at rest, the alpha subunit's bound to this thing called GDP. And when it's bound to GDP, it's just shut off. What normally happens is if something binds to a receptor on the surface of the cell, it leads to kind of a conformational shift where the alpha subunit kind of exchanges the GDP, which is the off signal, to something called GTP, which is the on signal. And when that happens, there's a separation of these subunits. The alpha subunit goes one way, the beta gamma subunit does something different, and they can signal downstream for growth signals. Just like CTLA-4 is kind of a normal feedback mechanism to kind of keep things in check, the alpha subunit also has kind of this check mechanism where it ultimately spontaneously converts the GTP back to GDP and returns it to the off position. So this is what's supposed to happen. Now, the mutations that were found were reported in 2008 by 2 different groups. A group led by Boris Bastian while he was at UCSF, and a group by Bill Harbour at Washington University. And what they found was that about 45 to 50% of these eye melanomas had mutations in GNAQ. And those mutations were located in part of the protein that affected the ability of the alpha subunit to switch the GTP to GDP. And so what happens is the protein can't turn itself off anymore. It's just always on. Again, like BRAF leads to constitutive signaling, this mutation leads to constitutive signaling down that G-alpha pathway. So further work was done looking at a larger subset of tumors, and here Boris Bastian's group looked at a large subset of these blue nevi, which are really non-cancerous tumors, primary uveal melanoma samples, and then samples of melanoma that had spread to other parts of the body. And again, in this larger subset, he showed that about 45% of these cases had GNAQ mutations. But he also looked at another gene called GNA11. It's related, has very similar functioning. And what he found was that another 32% of these cases had a GNA11 mutation. And these 2 mutations are mutually exclusive. You'll have one or the other, but not both, suggesting that maybe functionally these do the same things. One interesting observation was the prevalence of the GNA11 mutations seemed to be greater in the more advanced tumor samples. So in the non-cancer blue nevi, there was just a very low prevalence of these mutations, but if you look at the metastatic samples, the majority of them had a GNA11 mutation. If you look at GNAQ, the pattern was exactly the opposite, suggesting that maybe this GNA11 is a marker of more aggressive disease. Now, we also looked for mutations in another part of the gene affecting exon 4, and also found a smaller percentage of tumors harbor these mutations as well. That has some functional significance, which I don't think we need to get into now. But this is kind of a cartoon of what I call the G-alpha pathway. And this is really complicated, so I apologize. But basically, here's G-alpha, and here's G-alpha activated. If it's activated, it signals through a number of key growth pathways, but I'm just illustrating two here. One is the PI3-AKT pathway, as well as something called the MAP kinase pathway. And the finding of the mutations leading to constitutive activation of both AKT as well as the MAP kinase pathway, I think, give us some thoughts regarding potential treatment strategies that we didn't have before. And so you can imagine that perhaps if this is activated by that G-alpha mutation, perhaps if we shut down AKT, we might be able to get some anti-tumor effects. mTOR is another protein that may be worth targeting, something called PKC, something called MEK as well. And there are ongoing clinical trials looking at kind of these various therapeutic strategies, which again, in my mind, again, kind of mirrors the BRAF story for cutaneous melanoma. The largest trial that's ongoing right now is a trial looking at a drug called AZD6244 that blocks this protein called MEK. In the laboratory, if we take these uveal melanoma cell lines again, they're characterized for their mutation status. 2 have no mutations, 2 are BRAF mutant, 4 have these GNAQ mutations, and 1 has this GNA11 mutation. You can see that treatment with this drug, the AZD6244, with increasing concentrations, has some effects upon the tumors without a mutation, but certainly not as much as the BRAF mutant cell lines, and also not as much as the GNAQ, GNA11 mutant cell lines. Again, we show that inhibition of MEK with this drug effectively shuts down that MAP kinase pathway, but just in the cells with the GNAQ or GNA11 mutation. So in part based on that, there's an ongoing trial now. It's fairly large. It's being led by Memorial. It's a 14-center trial around the country that's randomizing patients who've not received prior chemotherapy with GTIC or temozolomide to either chemotherapy or the MEK inhibitor. If patients are randomized to the MEK inhibitor, they're allowed to immediately cross over to or if patients progress on chemotherapy, they're allowed to immediately cross over to the MEK inhibitor. So everyone's given access to this drug. We're monitoring enrollment so that we're going to have at least 40 patients with a tumor mutation in either arm, because that's the population that we think is going to benefit. And so where we are with the study now is we've randomized 50 of the 120 patients we need to complete the study. It is a little bit difficult because of the rarity of this subtype, but we do hope to have this study done in the next, hopefully, 1 to 2 years. There's a study of this drug called AEB071, which is a drug that blocks PKC, another one of those kind of nodes in the pathway that's activated by G-alpha. And this study just started. We're working on this in collaboration with Dr. Hody at the Dana-Farber, as well as a couple sites in Europe. And again, this is based on really promising preclinical laboratory data that suggests that this might be an effective therapy. So again, here's kind of this complicated pathway slide. We've talked about the presence of GNAQ, GNA11 mutations in 75 or 80% of ocular melanomas, leading to activation of this G-alpha pathway, as well as activation of the MAP kinase pathway. But there are other molecular and genetic effects that we may be able to target. And some of these may have to do with overexpression or amplification of certain cell surface receptors, such as things like MET, insulin-like growth factor receptor, somatostatin receptors. There's loss of key tumor suppressors, like something called P10, which is something that we might be able to use to our advantage to develop new therapies. And kind of based on this increasing understanding of the biology of this tumor, this is the current list of trials that are ongoing for metastatic uveal melanoma. The ones I've highlighted in red are the ones that are ongoing in the US, and there are a few also ongoing in Europe and Canada. of these, I think the rationale for these new trials are perhaps arguably a little bit stronger than the rationale for the prior generation. And so I really think that we are on the cusp of major progress in this disease. The trials here are trials like the PKC inhibitor trial, studies of drugs like sorafenib and sunitinib, which actually target a number of key receptors like vascular endothelial growth factor and so forth. This is a study of a drug like Ipilimumab, which they're conducting in Canada. There are some chemotherapy trials looking at chemotherapy with something called Genesense, which targets something called BCL2. This is a study that we're leading, looking at the combination of mTOR inhibition with a drug called RAD001, with a drug that's an analog of something called somatostatin. MD Anderson has a few trials looking at a drug called A12, which blocks IGF-1R. This is our trial, looking at the MEK inhibitor versus chemotherapy. Again, more chemotherapy trials. This is a drug of an HSP90 inhibitor led by Dr. Hody at Dana-Farber. And then we're going to have a trial looking at this HDAC inhibitor, histone deacetylase inhibitor, up in Memorial. That should be up and running in the next month. So again, there's a big push to develop new treatments for this disease. Kind of the last thing that I want to talk about is some of the work that's been done looking at liver-directed therapy. One of the unique things about this disease is it has a predilection for metastasizing to the liver. And so there are some patients who have liver predominant or liver only metastasis. And for that reason, investigators have looked at potentially just treating the liver. If we don't have to treat the whole body, if the disease is just in the liver, why not treat that? Some of the rationale for that is, one, the liver is the first site of metastasis in over 60% of cases in some series and may be the dominant site of disease. Two, our currently available systemic therapies appear to have limited effectiveness. Three, the amount of treatment we can deliver to the liver is greater than the amount of treatment we can give systemically because of the side effects. And then four, based on the vascular anatomy of the liver, this is a really good site of the body to do this. The tumors actually get the majority of its blood supply from the arterial tree, whereas the normal liver gets it from the venous blood system. So if you give the chemotherapy through the artery, most of it goes to the tumor, less of it goes to the normal liver. And so I just put here some clinical trials that are actually looking at liver-directed therapy. So there are a few of these ongoing now. One thing that I did want to talk about is this study here, which is a study that was presented by Dr. Pingpank from Pittsburgh in 2010, because this is actually the largest study of liver-directed therapy in a uveal melanoma population. And here they looked at a treatment called PHP, which is percutaneous hepatic perfusion, using a treatment called melphalan. And what they did is they randomized 93 patients with metastatic melanoma with liver involvement to either that melphalan liver-directed therapy treatment or best alternative care. And best alternative care could have been anything, a clinical trial, chemotherapy, or whatever. If patients on the best alternative care arm progressed, they were actually allowed to cross over to the liver-directed therapy arm later. And what you can see here is that the majority of patients put on this trial were actually ocular melanoma patients, and so that's why I just highlight this as a trial of some interest to this group. Although the treatment was put just in the liver with the hope of limiting systemic side effects, there were some side effects. So there was suppression of the blood counts that we saw, or that they saw, issues with liver toxicity as well. So this treatment wasn't without side effects. But what they showed here is that they met their primary endpoint, which was duration of control of disease within the liver itself. That's what they asked. How long can we control the tumor within the liver? And you can see here that the patients who got the liver-directed therapy did better than the patients who didn't. And so for that reason, this was deemed a positive study. If you look at overall progression-free survival, that is, if they had disease outside the liver and then it progressed, then that would be counted as an endpoint. That was also still significant, but again, the majority of these patients had liver-predominant disease anyway, so you'd expect those curves to be somewhat similar. Now, overall survival, which in my mind is the most important thing, that's what we need to do. If you look at overall survival, there was no difference between treatment arms here. Now here what they did was they looked at the patients who got the best alternative care only, shrank tumor better than best alternative care did. So about 34% of the patients got liver-directed therapy, got major tumor shrinkage, versus 2% of those who had best alternative care. So overall, I think what this data shows is that this DELCATH treatment can control tumor growth and can shrink tumor within the liver. There's no clear effects upon overall survival, but again, it did meet its primary endpoint of disease control within the liver. So I think this is a treatment that I think we need to talk about for patients with uveal melanomas with disease in the liver. So I'm just about to wrap up. These were the questions that I had hoped to be able to answer for you today. And in summary, I think uveal melanoma is a distinct disease entity from cutaneous melanoma. It has a unique biology, has a unique response pattern to systemic therapy. The currently available treatments for cutaneous melanoma have limited efficacy in uveal melanoma, although I think further investigation of treatments such as Ipilimumab or other immunotherapies is warranted. Hepatic-directed therapy has activity in the liver metastasis from uveal melanoma, but the role of this treatment in this disease still has to be further defined. Emerging insights into the biology of uveal melanoma have led to the development of a series of clinical trials which hold promise for positive clinical impact in this disease, and patient participation in clinical trials, both in the adjuvant and metastatic setting, remains critical to the successful development of effective therapies. So with that, I'm going to put this slide up here, which are a list of resources for patients with melanoma and uveal melanoma, which I'm sure a lot of you are aware of, and I'll end it there. Thank you.